Vent remains on or on standby. So that's probably down a little drop down. You just say the vent is on. Things that you would do as needed. Refused or communicated to. So if your patient doesn't want to go on the vent or doesn't want to go on BiPAP or something like that, that's where you would put that. Ventilator discontinued. You would put that if you DC'd the vent. Some of this is related to charges. Ambu bag at bedside. So always when you check that box, you look over and make sure an ambu bag is at the bedside with a mask. Because if your patient extubates themselves, you need the mask. What is not going to be at the bedside? The mask. It gets lost in transport a lot of times. And if you transported your patient on the vent with just the ambu bag and you just bagged them upstairs, you didn't have the mask because you didn't need the mask. And it probably got left in the ER. So they have extra masks, just go get one. Usually they run the tubing through the mask, so it's just hanging on the tubing, but the ambu bag is plugged in, is hooked up usually, should be. So anyway, be sure, if you're checking that box, you have actually visually looked at your ambu bag over there. If they do the chlorometer, you would do those as well, that's not common. Vent charge initial, it looks like your first, if you put the patient on, you would do that. Vent daily charge, subsequent. If it's the second day, then night shift's going to do that charge. And then if you're doing a vent check, you're going to check that box as well. That's every time you go in and do a vent check, you do that. Then the other ones, intubation assist, element placement, heart trach assist. If you do any of those things, you would check those boxes because that's a charge. And then vent ID, you go down to vent mode and vent model. Vent model is G5, and then vent mode, I guess that's where you put your assist control, and I'm not sure what that drop down looks like. And then also your VAP bundles, oral care, anytime you do that, you want to check the box that you did it, and then oral care performed by RT only, you have to check that box saying so they can charge for it. Is there really a charge? Not really. You might feel bad thinking, okay, I just swallowed their mouth, I don't want to charge for that. These patients, the hospital gets paid a lump sum for the patient to be in ICU. They don't really care what you did with them. You get X amount of dollars, and it's never enough. But for us to get our part to our department's budget, we have to do these charges. So they can say, okay, X amount came to the hospital, respiratory should get this amount. So they can figure out how many procedures we do, how much we get of the bills, that type of thing. So we want our piece of the pie is what I'm saying. So don't feel bad doing these charges, because basically we're just saying, yes, we did a lot of work in there, we want our share. So put those charges in. Okay, those are the only ones. If they're on home devices or whatever, you would do those boxes this time. The next page is BiPAP. I'm not going to go through BiPAP yet because I feel like y'all kind of seen that before. The next page I think is treatments. Is that what y'all have? No, I haven't really heard. If you do treatments or suctioning, you would fill out that page just showing everything that you did. I think I've probably seen some of the treatment stuff, I'm not sure. It's basically putting in your vitals, breath sounds, did you rinse the med, charging for the treatment, IPV if you did that, suctioning if you did that. So any of these extra things that you do will be on separate pages, just so you know there's a page for every single thing you do. Okay, now we're on to vent only, and that's the one we're going to look at right now. Okay, so this is, what is respiratory going to do every day? What are we writing down, or what are we accepting the numbers on? So peak airway, P peak, that's peak airway pressure, right? So what number is that on my patient right now? 44. Or 44 right here. So that's what you're writing down for that number, 44 or 45. And then minute ventilation total, where is that?
Right above it.
5.1, that's where that is. Tidal volume, expiratory tidal volume, should be exhale. Expiratory tidal volume in mils, so what are we measuring on the exhale side? Tidal volume, where's that? So what number is that? 334, 344, right? VTE mLs. There's that one. Tidal volume spontaneous. I'm on assist control. Are there any spontaneous breaths? No. Even though they can initiate, we don't call them spontaneous. So on this mode, we wouldn't have any. You should have that for SIV or CPAP, right? I'm on spontaneous, or I'm on SIV where they can take a spontaneous breath at their own volume. I would put something there. And we're going to go to spontaneous in a minute, so we'll see it. Rate total. So my patient's set for 15, but what is my total rate? This is gonna show up right here, total rate. Some of it potentially could be a spontaneous one. I'm set for 15. But what's my patient's actually doing 24, so I'm gonna put 24. What is the total rate? Do I have another place I think to put seconds in? Okay, IE ratio. You get controls, you'll get it. 1 to 5.3 right now. And then MAP, where's that? What is it? It's not mean arterial pressure in this situation. It's not from the monitor. It's not spelled the same on here. What does it stand for? Mean airway pressure. So this one says P mean. So your mean airway pressure is right here. So that's the 10. Remember, it's usually a pretty little number. Okay, if end-tidal CO2, if you're using that, you would say that what your end-tidal CO2 is. You put it on there. Plateau pressure, always less than or equal to the peak. Obviously, your plateau with nothing moving is going to be less than your peak airway pressure. So how do you do that?
It's
3 holes. So what do I do off this first? 3 holes. And let's scroll back to the end of the breath, and it's like a 32.2 would be my plateau pressure. Okay, obviously you can't get it on CPAP because you're not giving a machine breath. A plateau pressure is on a machine breath. On spontaneous or CPAP, they're breathing on their own, there is no plateau. RSBI. Okay, so for patients on CPAP but not on a TSB wean, she said this is usually a long-term vent spot. It's in another spot as well that we'll get to. And then alarms. Inspiratory pressure, high and low. Where do we find those? Okay, so what's my high pressure? 51, and my low pressure 5. And then minute volume high and low is the one right next to it, right? 10 and I put it to 0.8 because I didn't want it to alarm. That is a little on the low side, right? I would probably leave it around 4, 3 or 4, but right now it's at 0.8. So with that, don't put this number on. Don't actually do this number on the patient. Don't put it to 0.8. And then tidal volume high and low. She said they don't always put that. So you can put it if you want, though. She said. So she said they don't always put it. The 750 and 180. There you go. If you did end-tidal CO2 monitoring, you can put it on there. And then apnea interval in seconds. She said they don't usually put it on there unless they're on BiPAP or if they're on spontaneous, they'll document the apnea seconds. She said otherwise they don't necessarily document it. So PRN. PRN, BiPAP, or spontaneous. Okay, so that is the majority of the vent settings that you'll write down. The next page, what does your next page look like? Is that the treatment one? Okay, so if you did a treatment, you'll go to that section. If you did IPV, if you did suctioning, any of that, you'll go to those pages. Okay, the next page says TSB wean, but we're going to go down to the bottom where it says ET2 first. So here's my ET2. ET2 properties, cuff pressure. If you're on the IntelliCuff, you get it off the machine. Where does it show up on the machine? IntelliCuff. Okay, so I'm going to go right here to System. I'm going to hit IntelliCuff. And it'll tell you what the number is. I don't have it on right now. It's set to off. I can set it on and it'll tell you what you want to keep it at. And then it'll tell you what it is. So that's where you would find it. So System, IntelliCuff. I think you can get to it a different way as well, but right now
I think it's on the screen somewhere.
if you have it, if you have it on. Yeah, that's gonna say, I feel like I haven't gotten it this way always. But that is one way to get to it. So go to System and pop it up. There again, if you want to run your nebulizer too, this one's also on here. You can do pneumatic or aerogen, do it for 30 minutes. and turn it on to do inspiratory, exhalation, inspiratory, and exhalation. I don't know how they're running it at the hospital. We usually run it just on inspiration. But that's gonna be if you're running your nebulizer right here. I think the Aerogen, I think they just plug it in and run it that way. I don't think they run it off the vent. But if you ran a regular neb inline, you could run it right here, and this is where you would tell it to go for 30 minutes. Usually we just did inspiration only for 30 minutes. Hopefully it's done in 30 minutes. If you're doing inspiration only, it's gonna take longer. So then we would have to come back and sometimes reset it for 30 minutes. But it's nice that it'll turn off in 30 minutes. The old school ones, we have to come in and turn off. So, inspiration for 30 minutes if you're doing a regular neb inline. Anyway, that's where you would find that. Humidifier. How do I have that on? Some of these machines you can hook a SpO2 monitor to them. I don't think we have capability on this one, but you could put it in there as well. If you got put your patient on and you didn't know anything about them, when you put them on, then you came back and figured out how tall they were, you can go in and change that height. So just hit patient and it'll let you redo it. Or if you got it wrong. Okay, ET tube. Okay, so IntelliCuff, you'll see it on there. If you're doing the True Cuff, that's that little syringe. It'll pop up green or red, and you just put what it is. If it's in the red zone, you'll put MLT. I think that pops up. And then secured at. So where's my ET tube secured at? Where is it at secured on my patient? It's at the 24? Yeah, probably the 24 at the lip, something like that. So secured at 24, measured from lip, secured location, lip, secured by, comfit, anchor fast, tape, whatever you got. Secured the airway the first time you put them on the vent, you will do that charge. And then airway tape integrity, that's just looking at, is your tape good, is your anchor fast good, how does that look? Skin integrity checked, yes or no, and then site condition, just whatever the pop-up is. If you proned your patient, you would put it there. If your patient had stridor, that's only on extubation, you would document it there. ET tube exchanged. If your doctor changed out the tube, or anesthesia or somebody, check it there. Extubation, that's where you're going to check the box, basically so you can do the charge. And was your patient able to vocalize? That's part of your extubation checklist. So that's on the ET tube part, or basically airway part. Okay, TSB wean, the top part of this page. So if we have our patient on a TSB, let's say we put them on TSB, things that you would be checking for, there's the charge for it. FiO2 less than or equal to 50%, SAT greater than or equal to 90, check that box. We're not going to wean them if those aren't in place, right? PEEP less than 5, minute volume less than 15 liters per minute. Most of the time it's 10. I don't know why they adopted 15, but I guess that's still there. So these are weaning parameters, right? Getting the FiO2 down, getting the PEEP down. What's the minute volume? Less than 15. Heart rate, less than 140. Check the box. Respiratory rate, less than 35. SAT, greater than 90 and less than 160. SAT. I'm like, that's less than 160. If you have a 160 SAT, you're doing good. That is blood pressure. Systolic blood pressure greater than 90 or less than 160. So you're charting that. And then TSB, wean meets all criteria. So if they did good on their parameters and you met criteria on your TSB, you would check it there. Gag and cough, that's also just basically, do they have a gag or cough? You want to document that before you extubate them. And then did they pass their weaning or not? So check the box if they did. Weaning pass or fail, and weaning stop time. How long were they on? And then the weaning parameters, the other things that we look at, weaning start time, nib for vital capacity. So your nib is going to be that little thing over there. Vital capacity, how do you get them to do a vital capacity? What is a vital capacity?
It's your volume and
ERV as well. Right, vital capacity is big as, it's everything but the RV. So Blow out all your air. There again, you're telling this to a patient who has a tube in their mouth. Generally, a vital capacity is blow out all your air, big breath in, and blow it out, right? You're telling them to take a big breath in and blow it out through a tiny little tube. That's really hard to do. I just tell them, take a very big breath for me, and I look at the size of the breath. So tell your patient, exhale, and then big as you can. And I'm looking at vital capacity right here. I'm just looking at that exhale tidal volume and see what they can do. So big breath in and big breath out, and I'm just looking at that breath right there. So you're gonna find that on the exhale tidal volume because it's the biggest breath they can take. What is our minimum on the vital capacity? What do we want them to do? 10 to 15 mils per kg, right? Our tidal volume should be 5 mils per kg. Our vital capacity 10 to 15 mils per kg. So 15 is really a better number. Negative inspiratory force, that's your NIF or your NIF or MIF, whatever you want to call it. Spontaneous minute volume, there again, we want that less than 15 according to this. Our books all say less than 10. For your test, it'll be less than 10 liters per minute. If they need more than 10 liters per minute, they're probably not ready to wean, right? Weaning tidal volume needs to be at least what? 5 mils per kg, right? So 5 mils per kg on the tidal volume, 10 to 15 on the vital capacity. NIF, negative 20. Minute volume less than 10 liters per minute, but greater than 3 liters per minute. Obviously, if their minute volume is nothing, that's not going to work. And then RSBI. Once we put our patient on, and then dyspnea occurrence, check if your patient's dyspneic. There again, this is also kind of helpful if you check the dyspnea occurrence, your patient's dyspneic. The book has a board scale that talks about dyspnea and all that stuff. Most patients just put yes or no. That helps me. If I look back tomorrow, I want to see how they did on their TSB. I can look at all this information. And if you checked the dyspnea box, I can say at least, oh, it looks like they got short of breath. They checked the box. So I'm assuming that's why they failed the TSB. Or maybe the other numbers are out of whack. So if things are out of whack, you're going to put what time you stopped it and then document those things that are out of whack. So looking back, I can tell the doctor what happened yesterday. So be sure you document all of that because it's very helpful. Otherwise, it'll happen to you when you're working day shift and the doctor asks you why they did bad yesterday and the therapist didn't document anything and you're looking back going, I really have no idea. There's nothing on here. They didn't say dyspnea. The numbers looked good, so I'm not sure what happened. And he's like, well, why did they not tell you? I don't know. Yeah, you look stupid and you're mad. I hate to look stupid. I just say that. I don't like, let me find out. I'll call you at home. Why did this patient fail yesterday? I really wouldn't do that, but I've been digging through the nurses' notes everywhere to try to figure it out. So that just FYI, give that information in report. If you're day shift and you're giving a report to night shift, tell them why they failed the wean, or even sometimes there's a whiteboard in there. Write it on the whiteboard because night shift doesn't always give the same report to day shift that they were given because it doesn't really apply to them. So they're just hitting the highlights so they can go home. Night shift is a really different. Night shift and day shift are a lot of times they don't get along too well. They should. Night shift has a whole different set of problems than day shift does. Day shift is busy and gets interrupted with every single thing. But night shift doesn't have as many people. And if people are going to crash, they're going to crash at night. So you are left with crashing patients and less people to get it done. So, I mean, they literally, I've worked overnight. I worked nights a little bit, not a lot, but they're like running sometimes. I'm like, why are you running? And they're like, I don't know what shit's going to happen later. I'm like, okay, well, I've already worked 12 hours. I'm just helping you out. I'm not going to run, but you go, girl. I'm just going to walk slowly behind you. So yes, it is a whole different set of problems. So don't ever, don't ever judge them too much between each shift. Okay, so blood pressure, we talked about that. Yeah. Okay, so let's look for the RSBI. I'm going to put my patient on spontaneous and breathe for them. Okay, who wants to put them on spontaneous? Let's say we want to wean our patient, and we want to see how they're doing. We're ready to do a TSB. Who wants to do a TSB? Who hasn't put buttons? Honestly, we haven't put buttons. Okay, so we need to put our patient on a spontaneous breathing trial. How would you go about that? Yep. Have your lovely nails because you don't have to go to clinical. I'm like. So we usually like to put them on peak of 5, pressure 4 to 5. Let's say pressure 4 to 8, just to kind of get them started. We're pretending the oxygen would be down to 50, obviously. They would have passed their waiting parameters. Things that popped up when we went to this mode. What's the P ramp? These are questions that I will ask you on your checkup.
How fast it goes?
Right, kind of for comfort for our patient, right? Okay, and then ETS. The weird one. And then what it stands for, it's on exhalation. Something, I don't know what the TS is, but it cycles you to exhalation. It's where the flow slows down and it'll cycle you to exhalation. It's only on pressure supported breaths. Or pressure supported, pressure controlled breaths. Really, it's pressure supported. It's on spontaneous pressure supported breaths. So, when is the machine going to let you go to exhalation? Because since we added pressure support, we added pressure, so we're sort of helping you. So we need to help you cycle to exhalation as well. That's why it pops up. And then flow trigger, what is that?
Like how the patient is gonna trigger.
Right. So hard or easy to trigger the breath, right? Defaults to 5. If you wanted to make it easier, what would you do?
Lower.
Good. Okay. If you want to make it harder, how high can you go? Push that button. See if we can do that. Let's see. Scroll it on. Oh, 15 it says it on there. So you could go to 15. So potentially you could put it on. No, don't go to that. That's just making more flow go through the circuit. I don't even know how you could go to 15. You only have 10 flowing through the circuit. So I guess if your patient could suck 15 liters out of the circuit, they could probably have a nip of -20. I don't know. I'm not sure if that's how they do it sometimes. They just make it really hard to trigger a breath, and if you can trigger the breath, you're good. I don't know. Sometimes they do that, I think, to see if your patient can trigger a breath. Let's try it on pressure triggering. That may be the one they do. They may switch to pressure triggering because that's a negative number. If your patient can suck 2, -2. So if they could suck -15, we could say yes, they could potentially be extubated, right? If they can initiate a breath at -15, meaning they have to really suck to get that air. So that might be how they do it instead of using the little nip thing over there. I'm not sure exactly how they do it. I haven't done it that way. Switch back to flow triggering because I'll already done it. Okay, what is this over here?
The rate, pressure control, and backup rate.
Okay, so backup, if you go into apnea, it's got to know what to put you on. So it's going to default to the rate of 15, which is what we had before, the rate of 15, right? Your pressure control, we didn't have them on pressure control. This is a pressure mode now, so that's why it defaults to a pressure mode. So it didn't default to our tidal volume. We had 400 tidal volume before. It defaulted to pressure because right now we're in pressure. So, and it's defaulting to a really low pressure, right? Pressure control of 15. That is not going to give our patient a very big tidal volume. We usually do 20, 25, something like that. So it's very protective. It's going to give a breath. It's going to get 15 breaths, but they're going to be little. It's going to be very protective for your patient because it doesn't want to blast them. You can change that. If I had them on pressure control before and it was 20, I can change that to 20 if I wanted to. You can change your backup to match what you had before as far as trying to kind of simulate what you had before. And then your eye time percent, what's your eye time? Was 33% before, so it defaults to what you had. So you always want to just double check those backup parameters and make sure they look kind of like what you had them on before when you had them on full support. So double check your backup. Because if it doesn't apnea, that's where we're going. All right, okay, so let's confirm that.
What was the BTS one again?
That's where on your spontaneous pressure supported breath, it'll cycle you to exhalation. Instead of just keep it on going with inhalation, you gotta tell it when to turn off. So when the flow slows down to 25% of the max, it'll let you exhale. The only time we change it if you have a leak, it doesn't want to cycle. It doesn't ever slow down to 25%. I'm going down. It won't ever slow down because it's leaking out, so it won't ever meet anything. So if you turn it to like 40 or 50, it'll cycle to exhalation earlier, so it'll be a little better. Okay, my patient's having a lot of time going. He's really tight today. I think it's a break from the calendar. Okay, so let's see. I have him on pressure support extubatable. We like 5, but we're gonna try 8 for a minute. So how do you think he's doing? What's my tidal volume I'm expecting? He's how big is he? What do you say? Go to patient. I thought it might be on this page right here. 69 inches. His ideal body weight is 71 kg. So what's 5 mils per kg? 71 times 10 is 710. Half of 710 is like 350-ish. So is he doing that? No, he's really doing poorly. He's tired. I'm telling you, he's got diaphragm. Using his external muscle. Okay, so I would like for him to get 350-ish, right? Yeah, he's not doing that. Okay, so that's a fail on that part. What do I want his respiratory rate to be? Less than 35. Okay, what's my RSBI? It might be fine. That's where your RSBI can be a little bit misleading. So where do we find it? I have to bring it in. Go to monitoring over here. Your RSBI is going to pop up on your monitoring. Where is that? Might be on the next page. Next page. Yeah, it's on the next page of your RSB of your thing, and it says RSB. Okay, this one is 383. So what do we want it to be? Less than 105. So this one's accurate. It's saying your patient is breathing way too fast and shallow to extubate. So don't extubate your patient. Okay, so go to monitoring page 2. I think there's another way you can get there, but I know that way, and that's the way I do it. And it says RSB. Come now. I think you can get it through here too. Yeah, it's on there as well. You can get it to pop up on your front screen. I was like, I think I know. Okay, so RSBI is poor, respiratory rate's poor, tidal volume's poor. Should I extubate my patient? No. Okay, I've talked him down. Take a slow, deep breath. Let the machine do the work for you. Still a little better. Still not there, right? And maybe we gave him a little sedation because we thought it was anxiety. Nah, still can't get her done. He's better than he was. My RSBI is coming down now because I have a lower rate, a higher tidal volume, but it's still 194. So after we've chilled him out and talked him through it, he's still not ready to be extubated, right? Okay, and what else would we be looking at on the monitor? Heart rate, what is our cutoff for that, or what are we looking at on that? Not greater than 20%, which is about 20 beats, right? Not more than 140. Blood pressure, what are we looking at?
Greater than 90 over 60, less than 180 over 110.
Yeah, very good, yeah. So, and on this sheet, it just looks at systolic. I think it says less than 90 or greater than 160, but per the slides, yeah. 180 and 90 are cutoffs, right? Okay. So we're looking at blood pressure, looking at stat, not less than 90. And then accessory muscle use, diaphoresis, mentation, right? Confusion, things like that are also the things we'll look at. Okay, that's the big majority of them. Okay, so what's my vital capacity? Take a big breath in and blow it out. 500. Is that enough? No, we needed 10 mils per kick. He's 71 kicks, right? 71 times 10 is 710. So we needed at least a 700. That's a very minimal number, right? 10 mils per kick is not a lot. We needed at least a 700. We did not get there. So he wouldn't have even passed weaning parameters probably to make it to the spontaneous breathing trial. Before you do a spontaneous breathing trial, you almost always do weaning parameters first, right? So you know if they're going to even be able to do the spontaneous breathing trial. So before that, they have to be hemodynamically stable. You have to get your PaO2 down to 50 with at least a 60 PaO2. I mean, FiO2 down to 50 with a PaO2 60. So we would have done some preliminary things first, right? Make sure he's awake and alert. Can he squeeze? Can he lift his head? Do a nip. Is it at least negative 20? Do a vital capacity. We would have done those things before we even put him on a spontaneous breathing trial, and then we would look for all of those things that we just talked about. So heart rate, respiratory rate, knowing those normal tidal volumes. I'm going to apnea because my hand's tired. Okay, did that help? Kind of see how to put them into spontaneous and then see what you're looking for and find all the things that you would be giving in report. Alright, so now you know where our SDI is and how to find it. Oh, we went into apnea. Praise the Lord. Okay, but you can see the tidal volume in apnea with this pressure control of only 15. This stiff one is like 163. So you would have obviously, if they went into apnea a lot, number one, you wouldn't leave them on a spontaneous breathing trial. But just know you're ventilating them with a really small breath. So when that backup rate pops up, if I knew it was going to take more than 15, I'd probably change that to like 20 or 25. So that if they do go into apnea, it's giving them at least giving them a big breath to help them out. Alright, so now you know how to take them off. Not too hard. It's way hard. I mean, knowing the numbers is not the hard part. It's actually having a real patient on there that doesn't follow all the rules and knowing if they're going to be okay to extubate or not. And if they're not, you're going to have some fails. Everybody does. So, got your cool mist ready to go, and you know you're going to extubate them that day. And put them on my bed. If it doesn't work, if it's COPD, sometimes you extubate them straight to BiPAP. You know, you put a cool mist on them. All right, what questions do you have? We're done early? Sort of. Everybody, I'll let you have time to finish your worksheet. Play with the vent if you haven't been playing with the vent.